Good morning. Today I'll be reporting on some work that Meredith DeWitt and I have been doing. Meredith is currently in the hospital getting ready to have her first children who will be twins, so that we all wish her the very best. I want to acknowledge the help of Terry Davis and Jerry McClarty. Terry's with us today. She did a lot of the work in validating the realm test and taught us about how to use it, and has been helpful to us at every step of this project. Jerry McClarty has advised and helped us with statistics throughout the project, and both Dr. Davis and Dr. McClarty continue to be assisting us. Okay, health literacy has been defined as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. I suppose you'd need some health literacy in order to understand that definition. But the point is that if you can't read, at least at a basic level, it's difficult. It's more difficult, at least, to handle health decisions. Low health literacy has been associated with poorer outcomes in many chronic diseases, and health literacy can be measured. Measuring health literacy, the way we did it was with the realm test. This is a quick and easy to administer and to score, and it's been validated against longer, more complicated tests and found to be as accurate as they are. Okay, and this is the realm test. The first column is relatively easy, starts with fat, ends with incest. Next, a little more difficult, starts with fatigue and ends with directed. And the third starts with allergic and ends up with impetigo. And what we do is we ask the patient to pronounce each of these words, and if the patient pronounces it correctly, then we score that as a positive. And then with this relatively simple scoring, we can get an idea of that patient's literacy level. Okay, importance of adherence to viral suppression. Before we talk about effective literacy, need to know a little bit about this disease and how important it is to take your medicines if you have HIV infection. David Peterson and others followed 81 patients, some in Pittsburgh, some in Omaha, for a median follow-up of 7 months, and they measured adherence by what they call the medication events monitoring system. This is every time you take the cap off the bottle, it records the time that you opened the bottle. And then you can scan the cap and find out how many times the patient opened the bottle and what day and what time. Okay. If the patient took at least 95% of the doses, only 22% of those had an HIV RNA over 400. HIV RNA under 400 is really quite good. There's argument about whether people at that level will develop viral resistance, but they certainly won't develop disease progression at any time soon. If the adherence was 90 to 95%, 55% had an HIV RNA over 400. So just going from 95 to 90 doubled the number with an HIV RNA over 400. Went down to 80 to 90, 67%, 70 to 80, 71%, and less than 70% adherence, 82% of them had an HIV RNA more than 400. So taking just 2/3 of your required doses has a terrible outcome. Okay, how about this? Here is looking at the rise in helper T lymphocyte count. Come to us with a depressed helper T lymphocyte count, want to see it rise with treatment. With adherence over 95%, there was an 83 cell rise. Putting all the ones under 95% adherence together, only a 6 cell rise. Okay, days in the hospital. I know you all get frustrated with our AIDS patients being admitted to the hospital over and over. It's the ones who aren't taking their medicines. Here, the patients who were taking 95% of their doses, that group had only 3 days in the hospital versus 13 days in the hospital for the ones who weren't taking their medicines as regularly. Okay, even more important, progression to AIDS. This work was done by David Bangsberg and others on homelessly or marginally housed patients in San Francisco. They followed 330 patients, mean observation time 16 months, and they determined adherence by pill count. Okay, adherence less than or equal to 50%, that made up 31% of the sample, and 41% of them progressed to AIDS. 51 to 90%, that was nearly half the sample, only 8% of them progressed to AIDS. So 51 to 90% adherence, that won't guarantee you a very good HIV RNA, but at least it'll make your chance of progressing to AIDS in the next 16 months a good bit less. Over 90% adherence, that amounted for 20% of the sample, nobody progressed to AIDS. So adherence is a very powerful factor in how you do with your HIV infection. Okay, there have been a number of previous studies of HIV and literacy, and different studies have produced different results. Okay, literacy and adherence, this was studied by Dr. Davis and others, and they've published 3 separate papers on this cohort of 204 HIV-infected patients, some of them at the Northwestern Memorial Hospital in Chicago, some of them here in Shreveport, our patients. They measured literacy by the Realm test, and they measured adherence by the patient medication adherence questionnaire. And that isn't just did you take your pills or not. It makes you say what pills you took and when you took them. So you have to know something about your medicines to be able to, come out well on that adherence questionnaire. Okay, they found that low literacy patients were 3.3 times more likely to be non-adherent to their antiretroviral regimen. Okay, here's another study by Seth Kalikman and others. They examined the relationship between health literacy and objectively assessed HIV treatment adherence. Literacy was measured by a more complicated test, the test of functional health literacy in adults, the TOF-HLA. Adherence was measured by unannounced telephone-based pill counts and confirmed with pharmacy information. They studied 145 HIV patients in Atlanta and found that lower literacy patients had an odds ratio of 3.77 for non-adherence. This study was done by Drina Waldrop-Valverde and others. Hypothesis was individuals with low literacy and low cognitive abilities, cognitive impairment, would be at the highest risk for non-adherence. I studied 57 HIV-positive IV drug users. Literacy was measured by a different test, the Wide Range Achievement Test 3. Cognitive impairment was determined by neuropsychological test. Adherence measured by interviewer-administered questionnaire. Okay, they found that both literacy and cognitive impairment were important. High literacy, high cognition, they assigned a relative risk of 1. Low literacy, high cognition, odds to be non-adherent, went up to almost 1.7. High literacy, low cognition, about 3.5. Low literacy, low cognition, over 9 times as likely to be non-adherent. And if they used cocaine in the last week, they were almost 6 times as likely to be non-adherent. Okay, Carol Golan and others looked at predictors of adherence. What are the things you could tell about people that make them more likely to take their medicines versus less likely to take their medicines? They followed 117 patients, median follow-up 40 weeks, and this was a multi-center study. Okay, factors associated with non-adherence, not being black, having finished high school, have a high school education, an income more than $10,000 a year, no current alcohol use, no current drug use, a lower dose frequency, particularly if you had a dose frequency of 3 times a day when you had to take a pill during the day. That made patients much less likely to be able to do that, and more dose reminders. These are things like alarms that go off to remind you to take your pills, or boxes that you can put your pills in for each day and each time of day. They did not find associated with adherence gender, that was men and women about the same, whether they were employed or not about the same, whether they had children and how many children, and they didn't find an effective literacy level or what's called self-efficacy. Self-efficacy, as I understand it, is the belief that you can change by your own actions what happens to you. The opposite of fatalism. Okay, and they looked at they asked the patients who were missing doses, why'd you miss their dose? And here's what they got: busy or forgot, 62%. They were away from home at the time, 59%. A change in the daily routine, 42%. They were sleeping when a dose was due, 38%. Medication made them feel sick, 30%. They ran out, 20%. They took a drug holiday, 18%. Now this is a misconception a lot of patients have. They think, well, if I take this pill all the time, I'll, quote, become immune to it, which makes no biological sense whatsoever. But they, because of this folklore, they'll sometimes figure, well, I need to get the drug washed out of my body and then I can have a fresh start again. That's been shown over and over not to work, but there's some patients who persist in that. And they felt depressed or overwhelmed and didn't take it because of that. I've seen examples of all of these, and what you have to do is work with the patient and try to, not be judgmental with them, but try to get them to understand what you need to do to get around that. Busy or forgot, talk to them about their daily schedule, how to remember, how to work it around their busy times. Almost all our medicines can be given once a day or twice a day now, so we can tell them either take it in the morning when you get up, or after breakfast, or at night before you go to bed. Away from home, you can carry little pill boxes around in your pocket. Change in the daily routine, talk to them about how to fit it into their new routine. Asleep when the pill was due, take it before you think you're going to go to sleep, or take it when you wake up. Medication made the patient feel sick. Stress that the patient needs to tell you if they don't like the medicine, that there are plenty of other choices they can take, and get them on a medicine that doesn't make them feel sick. We're supposed to make patients feel better, not make them feel worse. Ran out. Talk with them about planning ahead, making sure that your applications for financial assistance are filed on time, and that you keep your appointments, and if you're running low on medicines, call. Took a drug holiday, we talked about that. Explained to him gently that it makes no sense, and felt depressed or overwhelmed. That's no reason not to take your medicines if they feel depressed. Refer them for care of that, but stress that not taking your medicines will just give you more to be depressed about, not less. Okay. This study by Michael Paschke-Orloff and others looked at HIV risk behavior among incarcerated women. This was not strictly an adherence study, but another study of HIV behaviors. And they found that low educational attainment, low literacy, and a history of special education and a history of learning disability would all be associated with higher HIV risk behavior. This was their hypothesis. In risk behavior determination, they asked, during the last 3 months, have you had sex without using a condom, or have you shared any part of injection drug equipment? And they found that educational level was important in this study, but the literacy level wasn't. See, if they had less than 8th grade education, they designated that as the reference group. If they had 9 to 11th grade, 0.35 risk. If they were a high school graduate, 0.30 risk. Observed literacy level, less than or equal to 6th grade, that was their reference group of 1. 7th to 8th grade, 1.26. And 9th grade or more, 1.37. Okay, this was another study by Dr. Paschke-Orloff. And here again, hypothesis was that low health literacy will be associated with worse adherence and less frequent viral load suppression. This was 349 HIV-infected subjects in Boston. And literacy was evaluated this time with the REALM test. And medication adherence determined with a 3-day self-reported questionnaire. Low literacy was, in this study, associated with an increased odds of adherence and increased odds of viral load suppression. Okay, less than 6th grade, and they've had over the 9th grade as their reference group, and those with less than 6th grade education, this is an unadjusted analysis, 2.23 times more likely to take their medicines properly, and twice as likely to have an HIV RNA suppressed below 500. Okay, this study was by Kathleen Noakes and others to determine the influence of health literacy on health outcomes in persons with HIV infection and AIDS. And this was more in terms of subjective symptoms of HIV infection, looking at body change, distress, depressive symptoms, and HIV symptoms in general, literacy measured by the REALM test, outcomes measured by questionnaires. Since this was a subjective study, they found higher literacy associated with poorer health outcomes in terms of symptoms. This study was by Julio Colazos, and he analyzed the influence of educational levels on baseline and follow-up characteristics and outcomes in 1,352 HIV patients. Found that higher educational degrees were associated with better baseline and also with better adherence to appointments in medicines, and also associated with better helper T lymphocyte counts, but not better viral load suppression. Okay, how about effect of education on AIDS mortality? This was a study of IV drug users in Spain, looking at the effect of educational level, high school or beyond versus elementary school or less, and these are mortality rates due to AIDS per 1,000 patient years, rate of people with the lower educational level, 11.1, and only 7.5 for those with the higher educational level. So the previous studies have been a mixed bag in terms of what the effect of literacy on HIV disease. So we wanted to do our own little study of to correlate health literacy with improved treatment outcomes in our HIV population. We didn't look at adherence, which is sort of a midpoint. We wanted to look all the way. Does literacy help you actually have a better outcome? So, we recruited the patients at their regular viral disease clinic appointments, health literacy determined by the Realm test, and charts were reviewed for helper T lymphocyte count, HIV RNA, opportunistic infections, and death. And participants were divided into adequate literacy and not adequate literacy groups for analysis. Okay, literacy we defined as adequate if they were reading at a high school level, not adequate if they were reading at 7th grade level or below. And a total of 115 patient charts reviewed, 68% adequate and 47% not adequate. And here's a pie chart, the adequate and not adequate. Okay, primary endpoints were either an AIDS-defining illness or death. So if you already had AIDS, but then you got cryptococcal meningitis or cytomegalovirus retinitis, that's a new AIDS-defining event. So that was an endpoint. Or if you died for any reason, that was an endpoint. Or if you didn't have AIDS and progressed to AIDS, that was an endpoint. If you moved away or just were lost to follow-up, you were censored at that time. So we looked for time to, and from the time the reading test was done to the next endpoint. Okay, among the adequate literacy group, 30 met an endpoint out of 53 patients for 46% of the total. Among the non-adequate group, 23 or 49%, roughly the same. And to do a statistical analysis of the higher literacy correlating with treatment outcomes in our population. Here we are with the results of those who reached a primary endpoint and did not reach a primary endpoint, of the ones with adequate literacy or not adequate literacy. And here is a plot, Kaplan-Meier plot. The blue is the literate, the red is the not literate, and this is time to an event. And you'll notice that they are quite similar. Dr. McClarty looked at this and found a p-value of 0.84. So there was, in this particular study, no significant difference between the literate and not literate in terms of reaching endpoints. Okay, conclusions from our study. We can say we did not demonstrate an effect of health literacy on outcome of HIV infection. We cannot say that there is not an effect of health literacy on outcome in HIV infection. And this is a fallacy which some people get into. They say the p-value wasn't less than 0.5, so there's no difference. That does not say that at all. All it says is that in this particular study, in this particular group, we were not able to show a difference. We don't come anywhere near saying there isn't a difference. Our study is nowhere near the statistical power to come anywhere close to that. Okay, so what's to do? Kollichman et al., and he was one of the people who did a number of these studies. He worked with Cherry and Kane on an educational intervention. And they had 30 HIV infected men and women with low health literacy as measured by the TOF-HLA. In adherence, they measured by a structured specific interview. Again, this isn't, did you take your pills? It's okay, what do your pills look like? When did you take them? Really, carefully try to determine their adherence level. Okay, and then they had an intervention. They had 2 90-minute sessions, 1 week apart, conducted by nurses. And then 2 weeks after the second of these, they had a 60-minute session. And these were not merely didactic. Didactic has been shown to fail both in AIDS prevention education and in AIDS adherence education. This include role-playing, talking about how each individual could incorporate the medications into his or her individual lifestyle, and really getting into the patient's individual issues. And the materials were tailored to a low literacy audience. Many of these patients had low literacy levels. And they found at a 2 and 3 month follow-up, adherence was definitely improved with a p-value of less than 0.05. So they, with their educational intervention, they had improved adherence. Okay, what can we draw from all this? I think we can say that adherence to medications is vitally important for HIV-infected patients. Studies of the effect of literacy on HIV medication adherence and disease outcome have produced mixed results. Some have shown that it's important, positive, some have shown less so. Literacy is a vital part of education, but literacy is not all there is to education. And there are more studies showing that educational level is important than merely that literacy is important. One of the things you learn in education is how to read, but you learn a lot more things. You learn about how to think about things, how to talk about things, how to organize a presentation, which I hope I did today, and you learn how to get to class on time and how to get work done. So that while literacy is a very important part, there are other things you learn in education too, which may also be important. Patient education can improve adherence, been shown. Patient education should not be didactic. Getting all your patients together in a room and giving them a lecture, that's been shown over and over again to be ineffective. Things like having them do little skits or make posters are far more effective than just telling them what they ought to do. The education should address the patient's individual medications, concerns, and schedules. Talk with the patient, set up a dialogue. I like to, instead of just telling them what medicines to take, say, well, here, and point out the pills in a picture. We could use this set of pills. They have these advantages and disadvantages. We use this set of pills. They have these advantages and disadvantages. And make the patient bring the pills to you. None of this, I'm taking the medicines, oh, yeah, I'm taking all my medicines, I take a blue pill. Make him bring them to you and tell you how often he takes each one, each time. And the education should be tailored to the literacy level of the patient. Don't talk about, protease inhibitors and things that the patient has no idea what you're talking about. Yes, that will impress the patient that you're a very learned person. It won't help the patient adhere to your medicines. Okay, and finally, for some patients, emotional factors like anger and denial may be important as well as cognitive factors. Some of the patients I've failed with have been some of the best educated, most literate ones. Recently, had 2 patients who died. One was a church music director, very highly educated patient. And another one was a counselor himself. He, thank goodness, did not die. We were able to pull him out at the last minute, but we had to have him in a facility for months and months to finally recover. I think in both of these, denial and anger were important. And you probably remember Dr. Scarborough's talk, Grand Rounds, a few months ago, about weight loss, in which he said that a lot of patients eventually fail with their weight loss. They diet and follow your recommendations for a while, but then they stop, and that important factors are probably depression and boredom. And I'm afraid that's true here also. Patients get sick of taking all these medicines, and they will say things to me like, I've taken these medicines for years. Why do I have to keep still taking all these medicines? If they were any good, they should have gotten rid of the infection by now. What you have to do is just be patient, listen to the person, and try to explain that the virus doesn't work that way, that we have to keep suppressing it, and be reassuring and listening and do the best we can. Okay, that's it. Questions? Yes.
Well, I'm wondering if maybe the reason you saw the mixed results in your study is, were you able to control for things other than literacy? We know that people who are poorly educated fall into at least two groups: those who are motivated and still trying to live a good life, and those who have fallen into, you could say, the non-potty trained population. It may be that they're contaminating the results. Could you control for this motivation?
Could, and Dr. Davis has done some work in which she looked at other factors and found that they are important. One of Dr. Davis's papers was about the interplay between self-efficacy and literacy. And patients who were more fatalistic were less likely to adhere and less likely to be more literate. You can see that if you say, well, it's all determined by the fates thousands of years ago. Whether I learn to read or whether I take a pill is less important. She found one of the other, I can't remember right off, was it social stigma? Yeah, patients who thought that it was shameful to have this disease were less likely to be literate and less likely to do as well. But ours was streamlined to be a pure study of literacy versus HIV, and I'm sure there are many confounding factors.
You know, one of the things with literacy now, the field has moved from looking at the patient's deficit to figuring out what healthcare can do to be more user-friendly. And one of the things I think all that mixed data shows is that knowledge alone is not going to make you adherent, not going to make you change behavior. So how can we help patients do that? And with adherence now, and self-report is still a weak measure of adherence, even if it's kind of, you know, tricked up self-report. But like blister packs, if it's if the way you have to dose it, it's many times a day. If it's and they're mini pills, if it's blister packs. And I wondered if you read any literature. I don't know the HIV literature anymore on reminders. When we did that work, it was before cell phones and text messages. And I remember one woman I talked to there that was HIV positive said, if I just had a calendar and you pasted my pills when I was supposed to take them, it would be helpful. But are prompts, when people are prompted on their cell phone or texted, is that proven, or does that bother them?
In one of the studies that I mentioned, I'm not sure I mentioned that part of it, but it was in Golan's study. They found one of the positive correlates with resistance was reminders, and that reminders were important. Aids like the medicine box, where it's easy if you've just got a bottle, think, well, did I take that? Yeah, I'm probably pretty sure I took it, when you really didn't. But if you've got a medicine box, you've got the pills for Tuesday morning there, I can say, well, no, I didn't take that pill this morning. And other types of reminders like cell phone alarms or places where you check things off for blister packs, those have been shown to be helpful.
It might also be interesting because your interventions seem to have an effect. I don't know if one of your interventions could be a motivational interviewing technique where you find out really what's important to the patient and then let them see how taking their medicine is important, because many of our patients may not understand, you know, like they might think of, oh gee, when I had the flu before and they gave me amoxicillin. I missed half the doses and I got over it anyway, so this is going to be the same thing. Maybe we need to try motivational interviewing to see if we can get them to buy into their need for treatment.
Yeah, I think that's a good idea. Anything else? Yes.
It may have been on there and I just missed it. What was your time frame for this 115 group of patients that you had in your study? I mean, was it a year, 2 years? How long did you watch them for that first defining event?
They were watched varying amounts of time, and I don't have that right now, but some were watched for years, some for only a few months. Only a few months because we stopped and analyzed the data, and also some of them left and we lost the follow-up, and we had to censor them at that time. Otherwise, a patient who lost the follow-up, it looked like he lived for 10 years, and we have no idea what really happened to him after the point 10 years ago at which he was lost. Yeah. Anything else? Okay, well, thank you for your attention.